Welcome to the American Heart Association Statements and Guidelines podcast, where we'll discuss clinical practice guidelines and scientific statements on various cardiovascular disease and stroke topics.
Hello, everyone, and welcome to our podcast today that I'm joined by Dr. Gladys Velarde, and we are going to discuss the recent AHA scientific statement titled Cardiovascular Disease Risk Factors in Women, the Impact of Race and Ethnicity. And this was published in April of 2023. Both Dr. Velarde and I were co-authors, and so it is great to join you today. So I am Dr. Jennifer Mieres. I'm a professor of cardiology and at the Zucker School of Medicine at Hofstra Northwell, also a clinical researcher, and also serve as Northwell's Chief Diversity and Inclusion Officer. I have been an AHA volunteer for the past 2 decades and have pretty much devoted my clinical career on gaining insights into the sex and gender aspects of cardiovascular disease. And so a pleasure to join you today. This has been a lifelong journey of unraveling the sort of aspects of women's cardiovascular health.
Oh, Jennifer, thank you so much. It's been a pleasure working with you on this important document. I am thrilled to join you here today. I am Gladys Velarde. I'm also a clinical researcher, educator, program developer. I am currently a professor and medical director at the Women's Cardiovascular Heart Program at the University of Florida College of Medicine in Jacksonville, where I also direct the fellowship program. I've been there now for over a decade, but I'm originally from Peru. And when I came and did all my training as an undergrad and medical student in New York, it was easy for me to see where my focus professionally was going to be, which is dedicating almost my entire professional career to women and heart disease. I've been a fellow of the American Heart Association for several years and over a decade, participated in committees in the Council of Stroke and Cardiovascular Health in Special Populations. And it's wonderful to be able to provide a document that highlights some of the things that we walk and breathe every day when we do our work. Currently, I am also excited to be a founding member of the NHLCC, which is a brand new organization positioned within the American Heart Association Office of Health Equity, supported by the AHA Somos Corazon ERG, and is doing amazing work already in decreasing disparities in the Hispanic community particularly. So thank you for having me here and for having an opportunity to work with you and run this podcast.
You know, Gladys, we have been on this journey for a long time. And I mean, I remember meeting you at one of our ClinCards AHA meetings many, many years ago. And we were united in sort of pursuing the mission of advancing cardiovascular disease for women, understanding the sex and gender aspects. And I think that, you know, we have made progress because we've been part of Go Red for Women for the past almost 2 decades. And we have seen the progress made because awareness is important. We have seen the number of women dying from heart disease decrease over the past decade because of the research focus. However, I think, as highlighted by Dr. Wenger's AHA presidential statement with CEO Nancy Brown, we have hit a plateau. And we have seen that women from underrepresented groups, vulnerable groups, Black women, Latino women, Asian American women, American Indians, are definitely bearing a heavy burden of cardiovascular disease and dying more so than white women. And I think that our paper wanted to sort of add some insight and address sort of this disparity.
Yes, first of all, I remember vividly when I was young faculty at the University of Rochester, bringing you as one of the thought leaders in the work that you were doing. And so, yes, you're right. We have been at this for a long time, and it has been gratifying to see how science has evolved and how we have been able to incorporate more women into trials and understanding them. But it's interesting that even though there have been gains, we still have these disparities in care and in cardiovascular disease, and so many gaps that we're beginning to understand in women in general. However, much more salient, and the disparities more marked in Black and brown women. And so, yes, it's an inflection point to say we've made gains, but we are going the other way, and these disparities and gaps should not be tolerated. And so I think this position paper and this manuscript that we produce, it speaks to those differences and where we have to go beyond the traditional risk factors.
Perfect. And I think as we were putting this document together, just as COVID was starting, and we sort of had to put it on hold, the presidential address was published in 2022, and it really allowed us to sort of pivot a little bit to hone in on the knowledge and the science that we have learned on the impact of social determinants of health. So, just to remind our audience, the traditional risk factors, we know hypertension, diabetes, elevated cholesterol, family history, smoking, obesity are the traditional risk factors, which all of our risk calculators include. But we have gained greater insight to understand the impact of the social determinants of health. So, Gladys, could you just elaborate a little bit on the impact and what we have learned on the social determinants of health?
Yes, as you mentioned, we know that we've been great at recognizing the traditional risk factors. We've have come a long way in treating them, in educating the public, and still, I have to say, there's still some gaps. We're not where we want to be, but at least we know what those enemies are. What we're beginning to recognize, and is getting more attention, is that the social determinants of health, where one lives, the stress that communities and certain population experience, the effects of racism, the economic status that you belong to, the level of education. All of these are non-medical factors that are really important, because we know that they are closely tied and impact the cardiovascular outcomes. We know that inflammatory markers increase. We know that there's less access to care. And so there's a science behind it, and that we are still beginning to understand, but we do understand that, and we do realize that they have significant impact. So, aside from that, obviously, are the new sex related risk factors that we probably can talk about a little bit more. But these non-medical factors are crucial to be taken into account, but we're just at the beginning of how we are assessing them, right? They're not easy to assess, but they're important to be recognized, and at least with that recognition will come the second part, the evolution of recognizing them, making them part of the medical record, and really acting on them.
You're spot on. I think as we think of redesigning or expanding cardiovascular care, I've always said it should be the patient as a partner model, and the patient and their families are part of the medical team. And if we understand where they're coming from, what their risk factors are like, especially the non-traditional risk factors, and we know those account for probably 80% of health outcomes, right? Because we in medicine account for 20%, then we could co-create and customize care based on their risk factors. And I want to share with you a story of a patient of mine from several years ago who was part of one of our research trials. who understood English, had pregnancy related complications with her third pregnancy. We didn't realize that that was a risk factor back then. So there were two things that we missed. So she was probably 48 at the time she presented with acute coronary syndrome. We had to put a stent in. We assessed for the traditional risk factors, did not realize that she had had preeclampsia with her last pregnancy a few years ago. Additionally, we gave her a script to, of course, dual antiplatelet therapy, all of the things that we aspirin, exercise, change your diet. And when she came back 3 months later with still an elevated blood pressure, as well as having chest pain and had sort of acute thrombosis, we recognized that she had not been taking her dual antiplatelet therapy. And I'll tell you, the big sort of aha moment for us was that even though she said she understood English, the language she spoke at home and the language that she did all of her thinking was in Spanish. And so she nodded, and it was really an aha moment that yes, we had missed the fact that, pregnancy related complications, preeclampsia, definitely predisposes to early coronary artery disease, but also a social determinant of health is communication. So I think we addressed this in our paper. Could you share with us your thoughts on, what we need to do in cardiology to incorporate one's preferred language, as well as some of the new risk factors or sex-specific risk factors for ischemic heart disease?
Yeah, you touch upon a non-medical factor that definitely impacts care in many communities because of different cultures. But the language barrier, it's a significant one. It is one of the reasons why when I was in medical school, going back, so many years ago, I was one out of two in my medical school class that were bilingual. And the need back then in New York City was tremendous. That need is now even higher because we have almost 19% of the population being Hispanic Latinos, with 67 to 70% of them of immigrant families are usually of Hispanic background that speak primarily Spanish. So the language barrier it's a real deal. And we know that concordant care helps. So having not only, we always talk about education, educating our patients, but for the Hispanic community specifically, you have a double whammy, is the education and the language. So it is important that we take note of that and make sure that it is part of the medical record, because you can have ancillary staff that can help mitigate those barriers. I think it is important to think of the multidisciplinary approach. For example, your patient, if somebody in the team had detected that her language proficiency and her health literacy was lower, maybe not necessarily just the cardiologist, but it could be the NPs, the PAs, the OBGYNs. Having diversity and expansion on the team creates richness as an outcome in terms of being able to identify these barriers. So that's, I think, part of your question. The other question is, or what you alluded to, were the six specific risk factors. We are actually quite fortunate to know that there's so much interest in knowing what is driving, and we still have a lot to learn. What is at the cellular level, what is at the hormonal level. We have six specific risk factors that pertain to women that increases their cardiovascular risk, and many of them are associated with their hormonal changes: early menarche, late menopause, pregnancy adverse events, eclampsia, preeclampsia, gestational diabetes. And we know that these risk factors not only impact the woman in the immediate or the intermediate term, but in the long term. And it also affects their offspring. And so these are really important factors that we have to obtain the data and and put it in the risk estimators and discriminators. But as you alluded earlier, we don't have those risk tools just yet. But at least recognizing them and making them part of the history of our patients to provide individual care is a must.
Spot on and clearly elucidated. I think part of our reason for writing this position statement had to do with expanding the cardiovascular paradigm and history so that our cardiovascular colleagues and team members, the entire cardiovascular team, will incorporate sort of the non-traditional risk factors, the pregnancy related factors, and move away from sort of the one size fits all approach to screening women. Another area that we touched on was that the high risk of women of cardiovascular disease, early cardiovascular disease in women with autoimmune diseases. And I know that in your practice, you've probably seen women come by with autoimmune diseases, probably no other risk factors. What could you share with us a story of how you approach these women and how you screen?
Well, what I can tell you is that in Hispanic women, particularly, we do see autoimmune diseases like lupus being quite prevalent, lupus, rheumatoid arthritis. And we work in conjunction with our not only endocrinology, but our immunologists to be able to identify patients and look for the best treatments for them. Now, I do see women with all these risk factors, diabetes, which is very highly prevalent, and obesity, along with metabolic syndrome in Hispanic women. When they have one risk factor, we always should be looking for another risk factor. And because these risk factors potentiate one another. And so those women need a special care, and they need a multidisciplinary approach to be able to treat them accordingly, because some of these medications may potentiate side effects. The medications that they may get for their rheumatoid arthritis or for their lupus may potentiate other medications. So we have to have a higher index of suspicion and vigilance for medication interference, for example. But yes, that's usually how I address it. I involve my colleagues, whether it's renal, endocrinology, or autoimmune experts, rheumatologists.
True. And so as we get our colleagues to expand the list of risk factors in their risk assessment, I think another disease that we see in women is polycystic ovarian syndrome. And we know that PCOS definitely exists in about probably 10% of our population. And these are women that definitely are at risk for cardiovascular disease and frequently miss during the screening process or the traditional screening process.
That's right. Women with PCOS, women that have had the factors that I mentioned earlier that are probably not paid too much attention to because they were young. Oh yeah, I had gestational diabetes. As a matter of fact, I just saw a lady today. It's 22 weeks pregnant, and she's expecting her second baby due to in vitro, which is another issue. The hormonal treatment that you do in vitro fertilization, also a red flag for us to be more involved in doing risk stratification appropriately. But this woman had her first pregnancy 3 years ago. This was her second pregnancy, and she had gestational diabetes at the time. And gestational diabetes after she was done with the pregnancy went away. And now she's pregnant again, 22 weeks, and she has gestational diabetes again. And so this is a red flag. And then you say, okay, well, let's just make sure that she is at higher risk for preeclampsia and eclampsia, even though we're talking about diabetes. So these are things that I often say this to the fellows and the trainees is when you're looking for something, don't shut your eyes and cover your blinds and look at one specific risk factor. Expand and see what else could be there. What else is at risk for this particular person? So this particular woman now has to be on aspirin because that's a reasonable recommendation to decrease the risk of preeclampsia when the time comes for her. And so those are things that the interplay, it's important to know, and it's important that we study more and we research more these women.
Thank you for listening to part 1 of this Statements and Guidelines podcast series about cardiovascular disease risk factors in women. You can find part 2 about race and ethnicity on the American Heart Association's official YouTube channel or at heart.org/podcast network. The data and statistics presented in this podcast are from the official guideline being released by the American Heart Association. Any and all personal stories and testimonies are that of the talent, hosts, and volunteers and are not reflective of any statements or position of the American Heart Association.